morning, respected Chairperson Sonia sir, Sir Sonia sir, dear colleagues and students. In a complex, dynamic and healthcare environment like ours, no department can function in isolation, and each department brings their expertise, their knowledge, and their skills on the table and makes patient care comprehensive and holistic. Whereas improper communication and improper references can lead to treatment errors, redundant testing, and compromised patient care. So the 13th PGCR is on a topic that is vital to seamless operation of our hospital, that is how to consult, mastering the art of communication and referrals, interdepartmental references. The chairperson for today's session are Dr. Divyansh Gupta from Urology Department and Dr. Rajnan from Gastro Department, and the moderator is Dr. Divyansh from the Critical Care Department. In the end, we will show a format in a PDF form that has been issued by DGHS in June 2024. That is about the referral format and how a department should give a reference and how a department should see a reference. And I will request the management that if we can make such type of a paper or a format for our hospital, so there will be uniformity for all the departments, and whenever we want, we can see the file that there is a reference and there is a referral given and taken. Thank you. Now I'll call the resident from the Critical Care Department.
Good morning, respected dignitaries, senior faculties, and my fellow colleagues. I, Dr. Sankalp, is going to present the topic how to consult, mastering the art of interdepartmental referrals. Interdepartmental referrals in a hospital setting is fundamental to the provision of quality patient care. Effective communication modes are important because they result in the improvement of patient care. A famous quote by Peter Drucker says, "The most important thing in communication is to hear what isn't being said." It refers to the idea that much of what is being communicated is done so through non-verbal clues rather than the actual words. This very truly fits in our medical world, and we come across patients who are comatose, in altered sensorium, intoxicated, and not being able to give us proper history. We'll be proceeding through our session in the following orders, starting with the objectives of giving referrals, covering sample cases with the commonly made mistakes in the references giving, and highlighting the mistakes and correcting them. Following by ISBAR technique, the implementation of ISBAR technique, and finally ending with the DGHS approved reference performers to conclude our session. The main focus of the session will be the understanding of when and how to seek consultation, a few effective communication strategies, and how to ensure comprehensive patient care. A patient can have multiple comorbid medical conditions, and a single medical condition can have multi-system manifestations. For comprehensive medical care, inputs from different departments are essential, which requires a robust referral policy. Interdepartmental referrals also serve an opportunity for interdisciplinary collaboration and sharing of knowledge among healthcare providers. By leveraging expertise and resources available across different specialties, hospitals can optimize patient care outcomes, enhancing diagnostic accuracy and improve treatment effectiveness. Moreover, referrals enable continuity of care by promoting coordinated management of complex medical conditions and facilitating follow-up care after discharge or treatment completion. Identifying the needs for consultation. There are few criteria for seeking consultation, which involves complex cases requiring specialized knowledge, uncertain diagnosis, need for advanced diagnostic tools or procedures, and second opinions for critical decisions. Establishing a multidisciplinary team approach to develop and implement a coordinated care plan that addresses the patient's physical, psychological, and social needs can be useful. Complex cases requiring specialized knowledge needs to engage in comprehensive care coordination involving multiple providers, specialities, and support services. Uncertainty in coming to a conclusive diagnosis, need for advanced diagnostic tools are the needs which we should identify for consultation. Document referrals should be accurate and comprehensive, including relevant clinical information, expected outcome from referral, patient's preferences, and any other specific instructions. A concise summary of the case should be prepared with necessary clinical information and patient's context to facilitate appropriate evaluation and management. There should be specific questions or objectives for the consultation. Referral for consultant's opinion should only be written by the consultant. PG residents should not close referrals on their own without discussing with a senior resident or a consultant. The case record of the file should have a sheet listing for various referrals taken in a chronological manner for ease of review. Departments should maintain rosters with contact information and availability for efficient referral. Patient and family should be informed about the referral process and advice given after the referral is seen. Do's and don'ts of referrals. Referrals should not be initiated promptly when specialized care or consultation beyond the admitting department scopes are needed. Avoid unnecessary delays in the referrals to prevent compromising patient care and adverse outcomes. Our utmost priority should be patient-centered care, considering patients' preferences, values, and treatment goals in referral process, and treatment planning should be kept in mind. Clear and effective communication with receiving department is crucial, providing necessary clinical information for appropriate evaluation and management. Maintaining patients' confidentiality and privacy when sharing information with other departments or healthcare providers is very important. Adherence to hospital policies, regulatory requirements, and best practices to ensure compliance and patient safety in interdepartmental referrals should be kept into consideration. So, to cite few examples and sample cases and how to go about with the whole referral process, I would like to call upon stage Dr. Gaurave Choudhary from the Department of Medicine.
No doubt that the primary aim of consultation is to provide better care to the patient. So if I can't do something, I need help of another specialist. Even if I can do something, I need help of someone who can do it better, so that the patient gets the best possible care in that setup. That is the primary aim. The second aim, which he mentioned in one of the lines, was to keep the relatives informed. It is very important that you tell the patient that, look, my patient is having a pulmonary problem, I have got a chest specialist see the patient and this is what they are doing. This reassures them that the best care is being provided by the hospital. And third reason, which was not mentioned, which is important in today's clinical practice, unfortunately, is to protect your own interests from medical legal point of view. So even if I can manage a urinary tract infection or a mild renal dysfunction, which may be because of dehydration, because the patient has been vomiting and having loose motions for last 1 week, I know that I can manage it. But still it is important to get the nephrologist's opinion, if the nephrologist is there in the hospital, to document that you got the best care for the patient and to save yourself tomorrow from a medical legal problem.
Very well said, sir. Good morning, respected teachers. Myself, Dr. Gaurave Choudhary from Department of General Medicine. I will be further discussing the real case scenarios. Case first. A 22-year-old married female was presented to emergency department with complaints of palpitation, fatigue, and generalized weakness for 3 days. Abnormal body movements with vomiting and soiling of floor of 2 such episodes in last 3 days. The history of present illness. Medical termination of pregnancy was done 12 days back at 8 weeks of gestation. Lower abdominal pain with pervaginal bleeding for 12 days. Dilation and evacuation was done for retained products of conception 3 days back at local hospital. Obstetric history was para 2, live 2 and abortion 1. She had previous history of 2 LSCA surgery. Menstrual history. Menses was previously regular. On examination, heart rate was 102 per minute. BP was 100 by 16 of kg. Pellar was present. She was conscious and communicating well. No significant finding on systemic examination was there. USG whole abdomen from outside was suggestive of retained product of conception. Further management. As patient's hemoglobin was 4.2 gram per day in our assessment, so patient was admitted in medicine department. Transfusion was done as per the local institution transfusion protocol. Bedside USG whole abdomen was done, which was suggestive of minimal ascites and bulky ovaries. And further transvaginal scan was advised, which revealed left ruptured ectopic pregnancy with significant hemorrhagic fluid in pelvic cavity. MRI brain and EEG were not showing any abnormality. So further, a Obs-Gynae reference was taken from medicine side, stating date, respected sir/ma'am, patient Mrs. ABC of severe anemia due to bleeding per vaginal, history of RPOC and TAT with hypoalbuminemia and ascites. Patient was complaining of consistently bleeding per vaginal. USG whole abdomen suggestive of minimal ascites, bulky ovaries. Transvaginal scan suggestive of possibility of ruptured ectopic pregnancy. Transferring the patient to your side and do the needful. Thank you, Dr. XY. So, can I even point out any mistakes in the given reference? So, these are the mistakes in previous reference. Time was not mentioned when the reference was made. Location of patient was not also mentioned. The patient is in ward or ICU. Type of reference was not mentioned. If it is immediate, urgent or routine. Does it require any bedside referral? This was also not mentioned. Consultation needed from faculty or SR or from a particular unit and department was not mentioned. No mentioning of admitting faculty, the department, the unit from which the reference was sent. Further, no mention of date, time, designation and staff of the person sending the reference. And the application should not be used.
Furthermore, the unit on call
For next case, I will call my friend Dr. Devataman Suri from Department of General Surgery.
Good morning everyone, I am Dr. Devataman Suri from Department of General Surgery and I will be discussing the next case. A 60-year-old male came to emergency department with complaint of pain in right lower abdomen for the last 10 days, nausea and vomiting which was gastrobilious for 8 days. Patient had generalized abdominal pain initially which later shifted to right lower abdomen. No history of fever, jaundice or constipation. Patient was admitted in General Medicine Department for abdominal pain under evaluation. Patient underwent routine blood and radiological investigations. The USG whole abdomen was suggestive of fatty liver grade 1, prostatomegaly grade 1 and minimal to mild bilateral pleural effusion. The patient also underwent the CT whole abdomen which was suggestive of appendicitis with chronic C-dog perforation, ascites with mild pneumoperitoneum and mild bilateral pleural effusions. There was a general surgery referral as follows. Respected sir, patient XYZ, 60-year-old male admitted to us with complaint of abdominal pain, CECP whole abdomen, suggestive of appendicitis with C-dog perforation. Kindly give your expert opinion in view of appendicitis and management. Thank you. JR1 General Medicine. Now, any mistakes in the reference?
one should not specify the cause of abdominal pain like appendicitis while referring the patient to the general surgery department. So it should be given that patient is having lower abdominal pain. So let them scratch their head regarding what is the cause of the lower abdominal pain. You should not specify the diagnosis. Let the general surgeon see all the investigation and advise accordingly. You should not pinpoint.
Anything else? Anyone else? Following information was missing in the reference end: date and time of reference, details of admitting unit and consultant, type of reference, whether it was immediate, urgent, or routine, brief history and examination findings, signature, name, date, time, and stamp were not there. Consultation needed from faculty or SR or from a particular unit or department. Consultation required for fresh opinion, follow-up, or transfer. Now, this is the format by DDHS, and it has all the columns and particulars which should be filled while asking for a reference. Name of the department, the location, the particulars, age, gender, the UHID, then the type of reference, whether immediate, urgent, routine, is it a bedside, whether it is a medical legal case. Then a brief admission diagnosis and procedure should also be mentioned, and the indication for reference and expected outcome from the reference. Now, for the next case, I will be calling Dr. Madhurima Bhati from Obs and Gynae Department.
Good morning everyone, I am Dr. Madhurima Bhati from Department of Obstetrics and Gynaecology. I will be presenting case number 3. A 25-year-old female, primary gravida with 30 weeks of period of gestation, came to labor room in evening with complaint of pain abdomen for 2 days, absence of fetal movements for 2 days, headache and nausea since morning, and no complaint of leaking or bleeding for vagina. Obstetric history was that she was primary gravida with normal past menstrual history, and she was known case of gestational hypertension since 1 month and was on tablet labetalol 200 mg thrice daily and tablet nifedipine 20 mg twice daily. Patient was admitted in labor room for further management and all routine investigations were sent. On examination, pulse was 94 per minute, blood pressure 190 by 110 mmHg. On per abdominal examination, uterus was 30 week size, cephalic, but fetal heart sound could not be localized in Doppler. Injection labetalol was given for controlling blood pressure, after which blood pressure was 180 by 110 mmHg. USG fetal well-being was suggestive of intrauterine death. Blood pressure was uncontrolled with labetalol and nifedipine. Along with headache, patient now had complaint of blurring of vision. Injection magnesium sulfate loading dose was given, followed by maintenance dose which was continued further. A physician referral was sent, which was quoted as, "Respected sir or ma'am, one patient Mrs. ABC is 30 weeks POG and IUD. Known case of severe preeclampsia. She is currently on tablet Lopate 200 mg TDS and tablet Nicardia 20 mg PD. She was given loading dose of magnesium sulfate, injection Lopate 40 mg IV stand and is having uncontrolled blood pressure. Kindly evaluate and provide your expert opinion. Thanking you, Dr. XYZ." In response to this reference, post-referral advice was done, which was quoted as TFR, Echo noted, patient HR 72 per minute, blood pressure 160 by 110 mmHg, currently on lab tablet Lopate and Nicardia, advised injection labetalol infusion at rate of 2 mg per hour, then titrate according to BP. BP monitoring and review SOS. Can anyone point out the mistakes in the reference that was sent? Mistakes in the reference that was sent were: date and time of the reference was not mentioned, location of patient was not mentioned, type of reference, whether it is immediate, urgent or routine, was not addressed, and if it requires a senior faculty or resident. There was no mention of department and unit from which the reference was sent. It did not mention whether fresh opinion is required or a follow-up or a transfer of the patient. There was no mention of date, time and sign of the person sending the reference. Mistakes in the post-referral advice were: no mention of date and time of reference, department and unit from which reference was done was not mentioned, use of non-standardized abbreviations, improper diagnosis and examination, how to follow the advice was not explained, advice regarding follow-ups was not mentioned, date, time and sign of the person doing the reference was not mentioned. I would like to call upon Dr. Sankalp from Critical Care to for further discussion.
So looking through all the three cases, we have come to the conclusion that there should be a clear and concise communication summarizing the relevant points in the history and current issues regarding which the consultation is required. Being specific about the reason for consultation is very important. ISBAR is based on SBAR, a system developed by the US Navy to ensure clear and precise communication between nuclear submarines. The ISBAR framework, endorsed by the WHO, provides a standardized approach to communication which can be used in a wide range of clinical contexts such as shift changeovers, patient transfer for a test or an appointment, inter-hospital transfers, and escalation of a deteriorating patient, or handovers, improving information transfer and patient outcomes. So here we will be playing two scenarios in which we will demonstrate that how helpful is the application of ISBAR technique in providing a consultation request.
हाँ मैं डॉक्टर मेहता बोल रहा हूँ एमरजेंसी से मेरे पास एक पेशेंट है जो अभी ठीक फील नहीं कर रहा है ये 65 ईयर ओल्ड एक मेल है हमारे पास में कुछ मेडिकल इशू है और इसका नाम राजेश कुमार है इसके हार्ट के साथ कुछ दिक्कत लग रही है और चेस्ट पेन भी है और कुछ और सिम्टम्स भी हैं और आपको अगर टाइम मिले तो बस तो टाइम में आके इसको देख लो और मैंने कुछ उसको मेडिसिन दी है आ रहे हैं बस ओके बस ठीक है
So, I'd like to tell you the shortcoming of the first scenario was that ISBAR technique was not implemented. So, can anyone tell me what were the mistakes in the first video shown? Any mistakes? Anyone else?
Very casual word use heart no problem है. It should not be use of medical terms. That we have already investigated the patient so far. So use some proper terminology so that it can be properly conveyed to the concerned.
So the mistakes committed were as follows. Location of the patient with the bed number was not mentioned. What are all the presenting complaints for which the patient is brought to the hospital was not told properly. Patient's past relevant medical history was not mentioned. Investigations done which can provide relevant clues to the diagnosis like ECG was not given. Patient's vitals at present were not mentioned. Medications initiated from the time of arrival in the hospital. The time period in which the reference has to be done, whether it is immediate, urgent or routine, was not told. Whether what is the referring doctor seeking from the team coming for reference was not told. Such problems can lead to delay in processing and attending of referrals, breakdown in communication and variation in the referral practices across departments. So, the same scenario will now be played with implementation of ISBAR technique.
हेलो हेलो हाँ डॉक्टर शर्मा मैं डॉक्टर मेहता बोल रहा हूँ एमरजेंसी से हाँ सर मेरे पास में एक पेशेंट है मिस्टर राजेश कुमार 65 ईयर ओल्ड में जो चेस्ट पेन की हमने ले गए पास हिस्ट्री में इसको हाइपरटेंशन और हाइपरलिपिडेमिया की हिस्ट्री है और कोई ड्रग एलर्जी नहीं है इसको चेस्ट पेन को उसने बता रहा है कि 2 घंटे से इसको हुआ है एट रेस्ट और प्रेशर लाइक बेड लाइक सेंसेशन बता रहा था टू लेफ्ट शोल्डर एंड लेफ्ट आर्म उसके बाद में इसकी जो एग्जामिन किया तो वाइटल्स इसके स्टेबल है बीपी इसका 140/90 mmHg है हार्ट रेट इसकी 80 बीट्स पर मिनट है रेस्पिरेट इसकी 18 menstrual minute SQ to 98 तीसरी में was इसकी S3 segment elevation है lead 2, 3 और AVS में और cardiac development troponin elevated है 0.4 बस मेरे को तो acute myocardial infarction है और urgent cardiological call चाहिए हुई वो आपको कैंसर ट्रांसफर करना है अब आने के बाद एसपी और प्रोटोकॉल से लोडिंग किया था अभी कंफर्टेबल और कुछ ठीक हो आप तुरंत आएंगे
So this was implementation of the SPA technique. So this becomes very easy for the doctor coming for the reference as he has almost all the necessary informations required to go about with the case. So follow-up and documentation is required, documenting the consultation request and response, implementing specialist recommendation, communicating updates to the patient and their primary care team. There are some common pitfalls and we should avoid them, like time lapse, incomplete or unclear information, failure to follow up on recommendation, not involving the patient in the consultation process. We should not delay referrals unnecessarily as this may compromise patient care and lead to adverse outcomes, whereas omitting essential clinical information and documentation when initiating referrals can impede the receiving department's ability to provide appropriate care. We should not ignore feedbacks or concerns from the consulted department. The process of referral should be clearly explained to the patient, the attendant families, by the referring department and should be explained about the advice after the consultation. According to the latest guidelines published by the Ministry of Health and Family Welfare Services in June 2024, referral process is a crucial component of high-quality comprehensive patient care in any medical institution. These guidelines provide a framework to all the hospitals on how to standardize and ease the process of referral. A structural framework of the referral form for interdepartmental referral is displayed here, beginning with the name of the department, giving the reference, location of the patient, particulars of the patient which includes the name of the patient, age, gender with the IP address, referral from the department from which the referral is being given with the unit's name, date of admission and date and time of the referral. Type of reference, whether it should be an immediate one. Immediate means to attend the referral within 30 minutes, be it an urgent one, attend within 6 hours, or a routine one. Attend before the next working day, preferably within 12 hours. Consultation required from a faculty or a senior resident, unit and department from which the consultation is required. Admission, at the time of admission, what was the diagnosis and what were the procedures if performed. Indication of the reference and what the doctor is seeking from the team which he is referring to. Consultation required is a fresh opinion, a follow-up opinion, or for a transfer. The person who is sending the reference has to give his name, date, time, and signature. Reference noted by once the reference has been received. Reference noted by with sign, name, and the stamp. And this is the post-referral advice performer. Reference seen by and at what time and date, and what he got on history and his examination, what was the diagnosis which he came up to, and what were the advices which he has given. And with his name, signature, and stamp. And if there is a follow-up to what time he needs to get the follow-up done, should be noted. So, to conclude the session, thorough preparation is very important. Clear and structured communication is a must to overcome any kind of miscommunication, and effective follow-up and documentation holds the key to success. Ongoing quality assurance and monitoring mechanism are essential to evaluate the effectiveness of the referral process, thereby identifying areas for improvement and ensuring compliance with regulatory requirement and best practices.